great honor and pleasure to serve as your host today. I'm deeply honored to join you for this very important gathering and look forward to guiding you throughout today's program. 오늘 저를 설명하게 된 아나운서 이승희라고 합니다. 정말 많은 분들께서 귀한 걸음을 해주셨는데요. 감사의 마음.
보건의료 전문가 여러분, 그리고 이 자리에 함께해 주신 모든 참석자들, 안녕하십니까? 저는 건강보험심사평가원장 강준호입니다. 먼저 2025년 건강보험심사평가원 국제심포지엄에 함께해 주신 여러분께 진심으로 감사의 말씀을 드립니다. 특히 먼길을 마다하지 않고 참석해 주신 해외 연자 여러분과 각국 보건의료 관계자 여러분께도 깊은 환영의 뜻을 표합니다. 오늘 심포지엄은 약제와 치료재료의 허가범위 초과사용 승인제도 현황과 개선 방향이라는 주제로 개최했다. 이는 임상 현장의 현실과 정책 간의 균형을 모색하고 환자의 치료 기회를 넓히면서도 안전성과 효율성을 함께 고려해야 하는 중요한 주제입니다. 현대 의료는 빠르게 발전하고 있으며 치료 접근성과 기술의 다양성도 그만큼 넓어지고 있습니다. 이에 따라서 기존 허가 범위만으로는 충분히 포함하지 못하는 임상적 요구가 점차 많아지고 다양한 국가에서 이를 제도적으로 어떻게 수용하고 있는가에 대한 논의 역시 활발히 이루어지고 있습니다. 약제뿐만 아니라 치료재료 허가범위 초과 사용에 대한 관리체계, 승인 절차, 환자 보호 방안 등을 종합적으로 살펴보며 제도의 미래 방향성을 적극적으로 논의할 수 있는 기회가 될 것입니다. 심사평가원은 공공기관으로서 단순히 규제를 위한 제도가 아니라 임상 현장의 현실을 이해하고 제도의 합리성과 효율성을 함께 고려하는 방향으로 정책적 토론의 장을 계속 이어가고자 합니다. 오늘 이 자리가 그 첫걸음이 되기를 기대합니다. 끝으로 오늘 심포지엄이 단순한 정보 전달의 자리를 넘어서 실질적이고 현실적인 정책 논의와 국제 협력의 출발점이 되기를 바라며 참석하신 모든 분들의 깊이 있는 구경과 활발한 참여를 기대합니다. 다시 한번 감사의 말씀을 드립니다. 감사합니다.
네, 여러분 큰 박수 부탁드리겠습니다. 네, 우리의 논의
안녕하십니까, 박준희입니다. 건강보험심사평가원이 이번에 초과사용 승인제도 관련된 심포지엄 진심으로 축하드립니다. 이런 부분에 대해서 여러 가지 제도를 마련하고 있지만 또 제도적인 한계가 있고요. 또 결국 또 의학적인 필요와도 간격이 있는 경우들이 있습니다. 여러분들께서 지혜를 모아주시면 그 지혜를 토대로 이런 문제를 해결해 나가는데 독해도 열심히 노력하겠다는 말씀드리겠습니다. 다시 한번 이번 심포지엄 진심으로 축하드리고요. 저도 내용 열심히 챙겨보도록 하겠습니다. 감사합니다.
네, 그럼 머리서 드릴 스크린 여러분 박수로 시청해 주십시오.
존경하는 대외 주민 여러분, 그리고 오늘 이 자리에 참석하신 보건의료 전문가 여러분, 안녕하십니까? 보건복지부 제2차관 이형훈입니다. 2025년 건강보험심사평가원 국제심포지엄 개최를 진심으로 축하드립니다. 심포지엄을 준비해 주신 건강보험심사평가원 강중구 원장님을 비롯한 관계자 여러분, 국내외 발표자와 토론자 여러분들께 깊이 감사드립니다. 오늘 논의 주제인 약제와 치료재료 허가범위 초과사용 승인 제도는 치료기회 확대와 환자 안전 확보 사이의 균형을 모색하는 매우 의미 있는 주제입니다. 특히 희귀난치 질환 치료제, 신의료 기술이 적용된 약제 치료제로 급속한 발전은 기존 제도 경계를 넘는 새로운 상황을 만들어내고 있습니다. 보건복지부는 국민의 치료 기회를 보장하면서도 의료 현장의 책임성과 환자 안전을 중시하고 있습니다. 오늘 심포지엄에서는 미국, 영국, 이탈리아, 일본, 대만 선진국의 허가초과 사용 제도에 대해 각국 전문가들의 경험과 범위를 공유하고 있습니다. 국가별 허가범위 초과 사용 승인 사례는 제도 발전을 위한 여러 의견을 함께 모을 수 있을 것으로 기대합니다. 한국적으로는 초과사용 제도 글로벌 트렌드와 정책의 시사점을 얻고 한국 정부와 초과사용 제도 방향성을 설정하고자 합니다. 여러분의 고견을 귀 기울여 듣고 정책에 적극 반영하겠습니다. 이번 심포지엄은 성공적인 개최를 기원하며 참석해주신 모든 분들의 건강과 건승을 기원합니다. 감사합니다.
파이팅! Thank you. Please remain on the stage. We will have one more round of photo shoot. 한 번 더 찍겠습니다. 죄송합니다. 저희 smile. 1, 2, 3, smile. And as we approach 연설의 제목은 허가 추가 제도 동향, 시사점, 그리고 제도적 개선 방향입니다. 바쁘신 일정에도 불구하고 또 시차가 좀 있습니다. 그럼에도 불구하고 오늘 실시간으로 온라인을 통해서 국제 심포지엄을 함께해 주셨습니다. With that, we'd like to now welcome Professor David E. Simon.
Thank you very much to the Health Insurance Review and Assessment Service and for the invitation to present here today. I'm deeply sorry I can't be there. I had brain surgery about 3 weeks ago, so if I say something wrong, please don't hold it against me. But I'm not cleared to travel, but I am cleared to give this presentation. And I'm here today to talk about off-label use. And what I propose to do today is achieve 3 goals. First, I'd like to describe regulation of off-label use in the United States. Then I want to talk about some trends in the regulation of off-label use globally, focusing on some major markets. And then finally, I want to review some of the proposals for regulating off-label use both here in the United States and other countries around the world. And I'll even offer some thoughts on my own views about what the appropriate, or at least most desirable form of regulation might be. So first, off-label use in the United States, it's a bit of a mess. It's quite different from many other countries. But to understand how it works, you have to understand some really basic, high-level principles of how the United States works. So we have a federal system. We have a federal government that regulates commerce between the states. And we have a state system, individual states that make up the entire United States. And each state regulates activities within its own borders. This means that the federal government has superior power when it's regulating, but it doesn't regulate everything. So you have areas where the federal government might regulate extensively, but still leave room for state action, and the vice versa might be true. And sometimes there's overlap where the states and the federal government are regulating the same thing. So that background is just to give you some understanding of how off-label use occurs. And so this diagram is not something you need to really know in detail. I'm going to walk through some of the particulars in the next few slides, but if I could just say a few words about why I put this up and what it's supposed to show. So I wanted to walk you through the pre-market the pre-market approval process for drugs and devices, and then how we get to off-label uses. So up on the left here, you see the device and drug types. So the first question is, what is the thing that the regulator, the Food and Drug Administration, is seeking to approve? So what's the application for? If it's for drugs, we have a rather robust system to evaluate drugs. We require extensive clinical trials, phase 1, 2, and 3 clinical trials. They can be up to thousands to tens of thousands of participants. And that would be a standard approval, a drug goes through a standard approval pathway. We also have something called the accelerated approval pathway, which requires a different, less robust form of evidence for diseases that have unmet needs. So for example, Alzheimer's disease is a disease that has an unmet need, and recently the FDA approved a drug through the accelerated approval pathway based on surrogate endpoints rather than clinical efficacy and safety. So in other words, they looked at, did the drug reduce amyloid plaque in the brain? And if it did in a substantial amount, that surrogate endpoint was kind of a proxy for Alzheimer's symptoms. Frequently what happens is the drug will get approved through accelerated approval, the manufacturer will have to do post-market studies, but they often don't do those studies, or even if the studies show the drug has no clinical benefit, the drugs remain on the market. Separate problem we're not going to discuss today. Devices are a separate category, and they're regulated much differently. Like in many countries around the world, not all devices are evaluated based on clinical evidence, and the same thing is true in the United States. So we have three classes of devices based on risk. Class 1 is the lowest risk, Class 2 is moderate risk, and Class 3 is the highest risk for life-sustaining, life-supporting devices. Class 3 devices are the most like drugs. They are usually supported in almost all cases by clinical trial data, although the clinical trial data is much weaker than for drugs. There's usually a few hundred, and sometimes even 50 participants in a trial, maybe even less. Class 2 devices, the moderate risk devices, typically go through the 510K pathway or the de novo pathway. The 510K pathway doesn't require typically any clinical evidence at all. It just requires showing that the device is substantially equivalent to previously marketed, legally marketed device, what's called a predicate device. So you have lots of devices going through this pathway. The vast majority of devices that get on the market every year are coming through this pathway, and almost all of them have no clinical evidence to support them. The de novo pathway is kind of a hybrid between the PMA and the 510K. And the de novo pathway shown here typically does require clinical evidence, but not as much as the PMA. And it's primarily used for devices that do not have a predicate. There's no substantially equivalent device, and the device is not a high-risk device, and so it gets shunted into this pathway. For each one of these, whatever it is for a drug or for a device, it's authorized, approved, cleared for particular indications. So for drugs, that means particular disease or condition, particular patient population, particular route of administration, and so forth. Similar for devices, particular part of the body, particular patient population. And that's the indicated use, but what we're here today to talk about is off-label use. So everything other than the things that I just mentioned are off-label uses, everything that's not on the label. So you have a whole bunch of possible off-label uses represented by this big circle here. And when I mentioned the federal and state law system, and the federal system in the United States, is because federal law and state law, along with practical considerations, operate as constraints on all of these possible off-label uses. So think of the possible off-label uses going through a funnel, right? And so you get through the funnel and you get to the actual off-label use. And so I'm going to talk about what are some of these constraints that limit off-label uses, both federal and state law. But for a moment, I just want to focus on some practical constraints. So one is evidence, right? Doctors aren't going to prescribe, in many cases, off-label uses that have limited to no evidence, or at least one would think. Doctors also have reputations that they want to preserve. So they're not going to willy-nilly prescribe off-label uses that could injure their patients and harm their reputation. They also care about patient health. They don't want to harm their patients, and so if they're acting in the best interest of the patients, you think that they wouldn't prescribe just any old drug for an off-label use. And finally, particularly in the context of devices, there are technical constraints. So devices, unlike drugs, are designed with a particular part of the body in mind. Whether it's a spinal implant, a hernia mesh, it becomes very hard to use that device in other areas of the body in many cases, although it does happen, but there are technical constraints. Okay, so now I'm going to talk a bit about how off-label use in the United States is regulated at the federal level, and what are some of the problems that we've encountered with this regulation. So first, the FDA is the primary federal regulator, but the FDA regulates labels. Its power comes from authorizing drugs to be on the market with a particular label or labeling. It defines labeling to include all written and printed matter, both affixed to the container and separate and apart from the container. So basically all manufacturer speech about a drug is considered part of the labeling. So FDA can regulate drug manufacturers by going after manufacturers that promote their drugs off-label, advertise their drugs off-label. But not all speech in the United States can be regulated, because we have something called the First Amendment. And the First Amendment does not allow the government to blanket ban truthful speech. And at least one court has held that includes truthful speech or off-label uses. So there's a gray area. And there's been a lot of litigation in this gray area. The FDA and the Department of Justice do prosecute cases for off-label promotion, but there's lots of cases where they don't prosecute or they can't prosecute, and there's firms taking advantage of this gray area to promote off-label uses. Second, the FDA doesn't regulate off-label uses as such. That is to say, it doesn't say doctors can or can't provide, prescribe or use drugs or devices off-label, except in very limited circumstances. It can set prescribing conditions like it does for mifepristone, which is a drug much in the news here in the United States. The reason is because the practice of medicine is regulated by the states, not by the federal government. And the practice of medicine includes prescribing practices of physicians. Third, the Department of Justice regulates off-label promotion through something called the False Claims Act. It's a law that was passed by Congress during the Civil War to prevent people from fraudulently obtaining reimbursement from the government, and it's been applied in the drug context where manufacturers cause physicians to prescribe off-label. The physician submits the prescription to the federal government, and the federal government pays for it. But the federal government wouldn't have paid for it had it known it was an off-label use. In these kinds of cases, firms can face huge monetary damages, hundreds of millions, potentially billions of dollars. But it's difficult to use. The DOJ is interested in big payouts, so it's going to take cases that have really strong evidence base and are going to generate a lot of return, and there's a lot of cases that aren't like that. It's also somewhat difficult to use in the device context because of complicated billing practices, but I don't have really time to go into it, but the long and short of it is when devices are billed in the surgery room, for example, they're not billed as a separate line item, they're folded into particular codes that surgeons charge, so it can be hard to show that the device sometimes was paid for or that the government wouldn't have paid for it had it known, so there's some complications there. And then finally, securities laws can be used to regulate off-label promotion. These cases typically involve financial firm disclosures and investors suing drug manufacturers alleging that they inflated their profits, projected profits, potential growth, because they were relying on off-label prescriptions that they were obtaining through illegal off-label promotion. Okay? But these cases are few and far between, they're not especially common, and they're hard to win for a variety of legal reasons. So these are the federal constraints that limit off-label prescribing by attacking essentially manufacturers and the limits of those. So there's some pretty big gaps there. Now, what about the states? You might think, well, the federal government can't regulate off-label promotion. What about the states? Can't they do it? And the answer is yes, but they don't really do it very well. So the state laws that affect off-label use that regulate physician conduct are things like tort law that say you have to provide informed consent when you provide a prescription or use a device. But there's no law, there's no tort law that says you have to inform patients that the use is off-label. In most cases, states require that the physician inform the patient that of the material risks of any treatment, but they don't necessarily have to tell them that a drug or device is off-label. And in fact, in many cases, the physicians don't even know. Malpractice. You might think, well, physicians that are prescribing drugs or using devices off-label with no evidence base are committing malpractice. And maybe that's an avenue to pursue. It turns out there are relatively few cases involving malpractice, at least compared to claims against manufacturers. And part of the reason for that might be that courts are reluctant to step into the shoes of the physician, and then physicians are reluctant to testify against other physicians. So very significant limits there. State laws that have been effective in some ways in addressing off-label use are tort law claims against manufacturers rather than physicians. These typically focus on a pattern or practice of the manufacturer that promotes off-label in a way that conceals information, risk information, or misrepresents information, or deceives physicians. Those kinds of claims can succeed, although they are quite difficult. And claims for defective products that a device wasn't designed in an appropriate way can sometimes proceed, but they also face significant evidence. Additionally, there's some state laws that protect off-label use or encourage it. So during COVID-19, there are several states that adopted laws that protected immunized physicians who prescribed hydroxychloroquine, which has been shown not to be an effective treatment for COVID-19. And there's also reimbursement laws that match federal law that basically say if you're an insurance company, you have to pay for certain off-label uses. This is really only in the cancer context, in the oncology context. And as I mentioned before, licensing boards are reluctant to regulate their members. They don't want to step on the toes of physicians who are out there practicing medicine. So you see that the state and the federal laws have some pretty significant gaps that need to be filled. But that's just the negative aspect of off-label use, that off-label use can be permanent. There is a positive aspect that I focused on in some of my research. So I just want to play a short video for you to illustrate some of that.
President Trump created the Make America Healthy Again Commission to investigate the causes of childhood diseases and conditions, including autism. As the search goes on for a cause, desperate parents are looking for treatments. For some, it means thinking outside the box. Dr. Slade Downer has tonight's Eye on America.
There hasn't always been this much joy in Mason Connor's world.
He did not vote.
His mom Caroline's concerns began around his first birthday.
He wasn't talking, no language.
Their pediatrician didn't seem worried.
I think he just thought he was a boy, and he would develop, and everything would be fine, but no. At 2.5, he was diagnosed with autism.
The Connors went on a mission, searching for anything that would help Mason.
We just started researching on our own, and that's when my husband Joe came across Dr. Fry in a research study that he was doing.
Child neurologist Richard Fry is one of many doctors searching for treatments that can help kids with autism.
We have 3 stations set up.
He's studying leucovorin, an inexpensive generic drug derived from the vitamin folic acid. It's currently prescribed to ease side effects from cancer chemotherapy.
It can really have a substantial impact on a very good percentage of children with autism.
In some kids, folic acid, essential for brain development, can't get in. Leucovorin bypasses that blockage and can help some autistic kids improve their ability to speak. Last up, he has a rocket ship. Mason's first words came just 3 days after he started taking leucovorin at the age of 3. The baby was purple. Currently, doctors can only prescribe leucovorin for autism off-label, which means repurposing a drug approved for one condition to treat another.
We've done the science, and the next step is that we want to get more funding so we can actually get it FDA approved.
But there's one big problem.
Why haven't pharmaceutical companies invested in clinical trials to study leucovorin to treat autism?
Leucovorin is an old drug, and you can get it for a very low price. So nobody's going to make a lot of money on it. So there's no reason for them to invest.
But there is a reason that 20 to 30% of all prescriptions in this country are off-label. That's because there are more than 14,000 known human diseases with no FDA-approved treatment.
I'm literally alive today from a repurposed drug.
Dr. David Fagenbaum is living proof of what's possible. A rare cancer-like illness almost killed him, but his research into his disease led to a drug meant for another condition.
It's heartbreaking to think about drugs being on the pharmacy shelf while someone suffers from a disease.
His nonprofit, Every Cure, uses the power of AI to scour available medical data on both diseases and treatments to uncover potential matches.
I think our system is just flawed. President.
Okay, so why am I showing this video? Well, we all know about off-label use and how important it can be. And it's to illustrate that there is innovation going on in off-label use despite or maybe because of some of these holes in the system. But Dr. Fagenbaum, who is at Penn, and others have noted that one of the problems is that many of the drugs go off patent. And once they go off patent, that is to say there's no patent protection over a small molecule drug, a lot less studies happen. In fact, almost no studies happen. So when the drug is on patent, the manufacturer has an incentive to find new uses, new indications, new formulations, because they can make additional money off of those. They can potentially even extend the life of their patent. But once the patent expires, there's really no incentive. And so that's where there's some programs, institutions that are coming into play, trying to fill this gap of this market failure. So we have an initiative at the FDA started by Heather Stone called CureID. CureID is a physician-led data collection tool. It was started during COVID, and it was meant for physicians to enter into the app the off-label uses they were trying to treat COVID. And the idea was we'll collect all of these different off-label uses and use them for hypothesis generation and go out and test those hypotheses. It's a really interesting idea, a really good idea. It's still in use. It's not clear exactly how widespread it is, but they are having some success. The FDA itself has also been instructed to use real-world evidence for new indications. So that might mean looking at existing EHRs, electronic health records, and other sources of information to try and repurpose drugs. So lower the level of evidence, potentially looking for what off-label uses are working in the market. And then there are nonprofit players like EveryCure and Dr. Feigenbaum who are trying to get support from funders to help them find these new uses of old drugs. But the sad reality is that there isn't enough money to go around. You really need a private investment and government funding to address all of the potential new off-label uses, and there's lots of proposals to do that. But that's kind of a separate question about, it's related to how to regulate off-label use, but it's not directly related to what do we do about manufacturers today. I'll talk about some more of that in a minute. Okay, so what are the takeaways? For the US system, we have a highly porous system. What do I mean by that? I mean that devices get on the market very easily, so it's very porous in the sense that lots of things get on the market ex ante. And then ex post, there's lots of experimentation going on. Bone graft that's supposed to be used in the lumbar spine is being used in the cervical spine. Hernia mesh is being used in other places of the body. A variety of different off-label uses, some good, some bad. Drugs are less porous ex ante than drugs. It's harder to get a drug on the market, but there's potentially a lot easier to use a drug off-label than it is a device. There's going to be a much greater number of uses. One thing I didn't mention entirely is that anti-cancer drugs are regulated differently. I think this is true in Korea as well. There's more liberal reimbursement policy. There's a different set of rules for how those drugs are regulated because so many of the uses in cancer are off-label. The FDA is trending towards quicker approvals, less evidence, and this is in some ways a good thing, in some ways a bad thing. It's good and it's generating greater access, but it's bad in the sense that we're not getting the data ahead of time and we don't have good post-market collection mechanisms to generate new evidence. We also have a lot of innovation going on in the US in terms of off-label uses. Again, this could be a good thing or a bad thing, depending on your perspective. And we lack sustained investment in off-label use research, both for off-patent drugs and often for devices, because manufacturers will get a device on the market through the 510K process and then start distributing information about off-label uses, and the uses continue and potentially harm patients, but there's no research being done because the manufacturer is making money on this. Okay, so that's the long and short of the US. I'm going to have to rush through a little bit off-label use in other parts of the world, and I just want to say a couple words about that. So I picked two major markets to talk about. The first is the EU. So the EU is in some ways set up like the US. There's a federated system. You have all of the member states. And at the federated level, the EU doesn't have a directive regulating off-label use as such. It's up to the member states, the equivalent of states in the United States, if you want to keep the analogy going, to figure out how they're going to regulate off-label use. And the member states have taken quite different paths. For a long time, for example, France did not have an express regulation governing off-label use at the national level, but that changed. In 2011, it became more restricted, and then in 2021, it unified its approach to off-label use by adopting regulations that displaced the previous 6 programs it used. And it tried to limit off-label use in a very European way from American eyes. it tried to regulate off-label use by requiring physicians to request that they be authorized to use a drug off-label, and that request had to be approved. There were certain exceptions like compassionate access and early access, but it was kind of a cumbersome process. It's not clear what effect that regulation has had on French prescribing practices. It's still estimated that about 1 in 5 prescriptions in France is written off-label, and physicians, like in the United States, generally don't know whether they're prescribing a drug on-label or off-label, so it can be difficult to track. What about some other countries? Not just France. I don't have time to go through all the countries in Europe, but needless to say, they have different views that when patients need to be informed of the off-label status of a medication, when patients need to be told about the absence of an on-label treatment, whether they have to, the physician has to follow scientific proven clinical practice. So there's a variety of things going on. But I want to jump to China because I think China is quite an interesting case. So up to 2021, it operated sort of like the United States or Europe. There was no express national law on off-label use. And there was one study done recently that looked at what kind of liability was arising out of practices involving off-label use. And you see at the bottom of the slide here, it said that most of the cases involving physicians or medical centers were about off-label uses that differed by indication or by dosing and frequency rather than route of administration or the age group. What was unclear from the study is exactly what we're supposed to make of the quantity of cases. To me, the total quantity of cases involving off-label use was quite low, and China has over 1 billion people, and there's only something like 45 cases in the time period studied. So it doesn't seem like, the time period studied, by the way, was 2014 to 2019, so a 5-year period. So it doesn't seem like there's a huge problem, at least a problem that's being dealt with by the judicial system. So maybe what China decided to do is say there is a problem, it's not going through the courts in the appropriate way, so what we ought to do is nationalize. So that's what they did. In 2021, there's a law that nationalized rules around off-label use. And there's another study done here that tracked from 2014 to 2024, before and after the physicians, the law that regulated off-label use, what happened to the number of cases in the courts involving off-label use. And basically, you don't have to read all the numbers, but basically the table tries to show that there's a decreasing number of cases. But the time periods don't really line up. 2014 to 2021 is a different time period than 2021 to 2024. In any case, there's still only 46 total cases in the time period. Again, it seems like a very, very small number of cases, given the population size in China. So what did this off-label law do? How did it actually constrain physician behavior, even though we don't really have enough information? It said that physicians can prescribe off-label if they get clear informed consent, although I'm not a scholar of Chinese law, so I don't know exactly what that means. And it said it has to be evidence-based. So basically, you have to tell the patient that it's off-label, and there has to be a sufficient evidence base that you would prescribe it. And then it also, I think importantly, required medical institutions to monitor and regulate physician behavior. So there has to be some kind of system in place that the health system is using to understand, what kind of off-label use is happening in my institution, and how do we figure out what's good and what's bad. The tables on the right here are the studies that looked at compliance with this law, and it found that there's pretty decent compliance. But we're still early on, we're only 4 years in, so we have a lot to learn. So those are some general trends. It seems like many countries are moving toward regulating off-label use at the national level. The US is still not going anywhere near that, and it's not going to for the foreseeable future. Okay, so now I want to skip to the final part of the presentation, which is the policy-oriented reforms and proposals. So there's really 3 actors that you want to look at when you're thinking about how to regulate off-label use. One is the manufacturer, one is the physician, and one is the insurance company or the payer. You might also throw in the patient, but I think that patient has less control in the situation. So I'm just going to walk through how we might regulate each one of these entities and what are the trade-offs when we do that. So manufacturer speech, I think, is probably the central focal point, at least in the US, because the manufacturers are the ones driving off-label use in many cases. So people have proposed things like maybe you want to allow a safe harbor for manufacturers to disseminate information about off-label use, but you have to verify that there's sufficient evidence to justify the communication. And you might do that through independent research. Here in the United States, we have something called the Patient-Centered PCORI, Patient-Centered Organization for Research or something like that, that's supposed to be doing this kind of research. Or you might have the manufacturer actually do the research itself, and then that research be vetted by an independent institution like the FDA. I don't know how different that is from FDA approval. I guess what I would say is that you might not need the same quantity of evidence, the same quality of evidence to at least communicate rather than get approval. Another approach is to allow limited off-label promotion. We tried this in the United States. Basically, there was a law that was passed that said if you want to promote a drug off-label, you can't do it unless unless you submit your marketing materials to the regulator approves it, and you file a supplemental new drug application for that particular use within a certain time frame. That law was eventually sunset, although there was a constitutional challenge to it. So that's one approach, is to kind of have a phase-in where you can talk about it as long as you get an approval. Another is to allow off-label communications but not promotion, and that's sort of what we have in the United States. We have manufacturers that can go around talking about off-label uses that are truthful, but they can't promote them. So they have to provide, there's certain guidelines the FDA has about what kind of materials you can provide and how you have to provide them. So you might try that. Another is you might want to ban just any off-label communications at all by the manufacturer. Probably not the best approach if you include published studies that would exempt those, but you could just say manufacturers, you can't go to physicians, you can't go to health systems and tell them about this stuff. You have to just publish it in journals. Another approach is to just require some form of approval or authorization for off-label uses like they do in France, and to say like if you want to, if you want to get approval, if you want to disseminate uses, you need approval, plain and simple. You might, in addition to these things, require data collection and reporting for off-label use. Here in the United States, there are guidelines for when manufacturers have to report adverse events. If those adverse events concern off-label uses, you might want manufacturers to do more to find out about how often is this off-label use occurring and do more investigation and follow-up regarding that off-label use. You also could increase tort liability, that is liability for promoting drugs off-label, and that might disincentivize manufacturers from discussing it. And you can implement these regulations at the national level, the state level, or the industry level. So the national level would be federal law, state level would be state regulation, state passing a law, licensing, state tort law, and industry regulation is basically self-regulation, and that's what occurs in most of Europe. There's actually, manufacturers actually sue each other for violations of off-label promotion rather than the government doing so, although that seems to be less effective than having a regulator do it. Okay, so what about models for reform, physician standards and rules? And I know I'm coming up on time, so I'll try to be brief. So we might pass a national law like in France or China that says physicians can only prescribe under certain conditions. Or we might just increase tort liability for physicians that prescribe off-label. We might have to do something different. We might have to, instead of relying, at least in the United States, relying on other physicians to testify as to what's normal, we might have to develop some other kind of standard. We might rely more on professional societies, like in the United States we have the National Center for Cancer, my acronyms, it's the brain surgery, just give you a break. Professional societies like the NCCN rate drugs based on their effectiveness, and so maybe we fold that into the mix and make physicians licensing and state prescribing laws match some of these more independent societies. So those are options for regulating physicians. Other ideas involve looking at the particular practice areas in which off-label use is is happening and adjusting liability accordingly or adjusting regulation accordingly. The Chinese law, for example, is framed very generally, so it's flexible enough to adapt to different practice areas where off-label use might be almost mandatory and others where it might not be. Integrating clinical practice guidelines into practice is very challenging. Physicians just don't seem to want to do it very much. But that might be another way of decreasing the amount of off-label prescribing. And then finally, something I propose, which I call reverse detailing, is where you actually pay somebody to go around promoting the off-label uses that are most effective. Instead of having the drug companies promoting whatever off-label uses they want, you promote the ones that have good evidence base, and you try to get physicians to prescribe those, because those will often be cheaper than the non-brand ones. Okay, and finally, then we come to insurance and reimbursement. So we have state laws that can combat reimbursement of off-label use. We also have things like indication-based pricing and value-based pricing that try to tie the payment amount to the evidence underlying the use or the value that the use provides to somebody else. So the indication-based pricing is we pay based on the indication, how much evidence supports it. Value-based pricing is we pay based on the social value of the use, how many qualities does it provide. And these things could be, I think, very effective in reducing off-label use. Even in a socialized system where consumers pay very little, you can have consumers actually pay quite a bit more if they're getting an off-label use. Prior authorization is a common tactic here in the United States that's used to limit all kinds of health services. It requires the physician to fill out paperwork explaining why a drug or device is necessary or procedure is necessary. You could do the same thing for off-label uses, and in the process you can get information about what the use is for. Step therapy is another tool in the United States which requires you to use certain drugs before others, and so before you try an off-label use, you might have one particular off-label use, you might have to try something else first. So that might limit harmful off-label prescribing. The challenge is that off-label uses are frequently cheaper because they're often off patent. Okay, so I'm coming now to the end. I promise. The question is, what do we do? Well, there's inevitable trade-offs. If you have less regulation, you're going to get some benefits. You're going to have lots more experimentation, but you're going to have more potential harm. More people are going to be getting hurt because you're going to have a lot more false negatives. You're going to have increased access to many drugs and devices. People are going to have things that they never would have had before. But again, it comes with the risk of increased harm. So if you're going to take a regulatory approach that's more lax, I really think you need very strong data collection, incentives to monitor, incentives to study, and often these things are not present. Like in the United States, the incentives to monitor are quite low, and the incentives to collect data and do research studies on off-label uses can be quite low, especially after a patent wears off. In the device context, sometimes there's just no incentive. The off-label uses just keep happening, and the manufacturers get paid for them. They don't have any incentive at all to study them. But on the other hand, if you go with more regulation, you're going to constrain the number of uses that physicians innovate. And you're going to constrain what manufacturers can say. And so physicians you have less information. Now, that also may translate into less potential harm, but it's going to restrict access and treatment for some patients. So we have these trade-offs. They're not things that we can ignore. We have to confront them. So what ought we to do? Like, that's the ultimate question, right? And I'm not going to give you the answer, but I can kind of tell you what I think matters. So local practices matter a lot. What happens in rural China or rural Alabama is going to be much different than what happens in cities like Shanghai or Seoul or Boston or Chicago. In major cities, there's going to be more information, more treatments, more available. In rural areas, less so. And so you might have different practices that accommodate those resource differences, those knowledge differences. You're also going to have different drugs and practice areas that are going to rely on some of these things more than others, and you have to take account of that. I do think that if you're going to have significant number of off-label use, it's really important to have a strong regulatory system at the approval stage. So where the United States is falling quite short is in the device space and increasingly in the drug space. There's very little, compared to drugs, devices have very little regulatory approval to get on the market. And then they're being used, sometimes these devices are being used for the first time on a patient. The patient may not have any idea that the device has never been used in a human being before. That's a problem. So if you had a system that was more strict up front about studying the device, you might be able to have some give in the system later on. Say, okay, maybe we'll try some off-label uses if it's done appropriately. Likewise, speech regulation, I think, is quite important. It provides an incentive for firms to do the kinds of clinical studies that they need to do to show that their drug or device is effective. If they can say whatever they want about the off-label uses, even if it's truthful information, if they can provide truthful information, that is often not necessarily the best information. Also, prescribing and billing systems matter a lot. Particularly for drugs. In the United States and in many countries, you don't know what's being prescribed on or off label unless you go to the medical chart and you figure it out. Doctors don't record that. And I think that if they did, we'd have a much better understanding of what kind of off-label use is occurring, what kind of benefits does it have, what kind of harms does it cause. Likewise, with billing, it's important to understand what's going on in the operating room, how is the device being used, who's paying for it, and so on. And regulatory enforcement matters. If you don't have a regulator that's prepared to take action against firms that violate any regulation, the regulation is not really effective. And we're going to see what happens in the United States with respect to this, but we don't know. So what's the optimal regulatory system? I think we need strong pre-market approval standards, limitations on promotion unless there's some new approval to incentivize research. Here in the United States, I'd like to see some stronger informed consent laws because many times patients don't know that the drug or device is off-label. Frequently, patients don't know what kind of device it is that's being implanted into their body at all. It's a tricky question, but I think some more robust informed consent laws can help. Reimbursement is also a key component because it can regulate how physicians prescribe or use devices without actually telling them what to do, but it's very challenging to implement for some of the reasons I've mentioned. And I'd like to see limiting money and increasing evidence, limiting money paid for bad off-label uses, and increasing the evidence and clinical standards to drive high reimbursement rates. The last 2 points are, we really have to collect better information about off-label use because we're not getting it from clinical trial data. So it's really important that health systems think about how do we monitor what's going on in the marketplace and how do we fold that information back into our assessment of what we want to pay for and how we want physicians to prescribe and what we want manufacturers to say. And then finally, it's important to have neutral evaluators of existing evidence. And for off-label uses, this can be quite difficult because the published studies don't provide individuals with the raw data set. So we might push for the raw data from studies of off-label uses conducted by manufacturers to be public. So those are my suggestions, and I'm sorry that I went over time, but I hope that you learned something, and I look forward to learning something from all of you. Thank you very much.
네, 그럼 큰 박수 부탁드리겠습니다. 그리고 규제, 이 두 가치가 양립하기 위해서 데이터링, 모니터링 필요성 말씀해 주셨고 다양한 연구의 필요성까지 언급을 해주시면서 몇 가지 고려사항에 대해서 잘 설명을 해주신 것 같습니다. 말씀 대단히 고맙습니다. 자, 이어서는 기조연설 함께 더 청해 듣겠습니다. 이 자리 이를 통해서 논의될 내용들에 대해서 방향성을 설립해 주시는 기조연설을 준비해 주셨다고 합니다. 자, 여러분 이제 준비가 되신 것 같은데요. 따뜻한 박수로 무대로 모시겠습니다. 활용해 주십시오.
First of all, I'd like to sincerely thanks to the organizer to provide me the opportunity to speak at this wonderful international symposium. In particular, I'd like to acknowledge Dr. Bang Jung-gu, President of HIA, for his leadership and also strong support in making this wonderful event possible. So as you can see, I will present off-label use in South Korea, current status and future directions. First, I'll present the current status of off-label use in Korea and compare it with the systems in other countries. Then I will share survey results from the physicians at leading hospitals on their experience with the off-label use system, along with its kind of strengths and also barriers and limitations. Finally, I will suggest several recommendations for improvement of the off-label use system in Korea. Since the translation is being provided now, and also most majority of attendees are Korean, I will continue my presentation in Korean from the next slide, so that the message, the meaning of message, can be conveyed more clearly, I think.